Good morning, everyone. I am Emily, and I'm an evaluator here at USET. Brian just started recording us, so you are being recorded. Welcome to our session today. If you haven't done so already, I'm going to invite you to mute yourself, and please don't take offense if you are muted during the presentations, unless you're the presenter. If this is your first session and we don't already have your contact information, please go ahead and share your name, affiliation, and email in the chat box. If you're only joining us by phone and you're not already on our contact list, you can email me. My email is efield, that's E-F-I-E-L-D, @usetinc.org. If you send me an email, I will make sure you get added to our contact list and get all the presentations after the sessions. And towards the end of the session, I'm going to be sharing an evaluation link. It's super quick. If you could give us some feedback on how we can improve these for you, that would be wonderful. And that is all I have.
Great, thank you. Taloa, do you want to do staff introductions that are presenting today?
Sure, we have a little bit of change to the agenda that was sent out. Dr. Johnson will be speaking first, and then Christy, Dr. Johnson is the Chief Medical Officer at the Indian Health Service Nashville area office. And then Christy will give us some updates on the testing numbers, and we will hear COVID updates from Dr. Mera last. So I can go ahead and pull up Dr. Johnson.
There's also another correction to that. I'm actually giving Christy's updates today.
Okay.
And Dr. Johnson is sharing her slides. She will be sharing her slides.
Okay.
Brian, do you want to get started at the beginning, or you want to go after I finish my presentation? I wasn't sure.
I'll go real quick.
Okay.
So I'm giving the updates on COVID in the area that Christy usually gives. With 26 sites reporting, there was 9,217 tested this week, or that have been tested, which is up from 7,832. There are 1,046 that are positive, which is up from 979. And we have 7,568 negative, which is up from 6,388. And here you can see the incidence of cases per 10,000. You can see that our counties, which is the top line, is above the states and the United States. So there's a lot more going on in the counties surrounding the reservations. And that is all I have. So we'll switch it over to Dr. Johnson. You're on mute.
Thank you for that. Good morning, everyone. Today's presentation, first of all, I want to thank USET for inviting me to talk about lung disease in the COVID-19 disease. I wanted to just let you know that my focus will be on more of an outpatient setting and not inpatient setting. We've been in this for a few months, and I know that we've had lots of talks about the management of patients that are in the ICU and the diseases that are associated with that. So I want to focus in more about the management of patients, talking about COVID-19, lung disease, and the management of those patients. Our objectives today will be that we're going to discuss lung disease that's associated with COVID-19. We'll talk about the different, yes.
Can you share your screen?
Hold on one second. I think I may have, let me try it again. I don't know what happened with this sharing of the screen, sorry. Share screen. Okay. Let me see if we can get in presentation mode. Okay. Is it sharing now? Great. Sorry, guys. Okay, so our objectives, again, we'll talk about discussing the lung diseases that are associated with COVID-19. There are a few there, we're probably very familiar, but we'll talk about the progression of that lung disease. We'll also look at some of the imaging, CT scans, chest x-rays on what you would see with those patients with that disease. But the most important part about this is strategies that we can do as providers to try to prevent patients from progressing to that chronic lung disease. There's some things that we can do if we're treating early that will prevent those patients from getting that scarring or could help prevent that. And then we'll talk about, as a method of trying to prevent that progression, what we're doing for patients who are diagnosed with COVID and what that follow-up looks like. So we're all familiar with the fact that COVID patients are more likely, when you do chest x-rays, imaging, to have a pneumonia, but that pneumonia also can progress. It doesn't just stay as pneumonia. A lot of our patients, the reason why they have significant difficulties is that pneumonia progresses to an acute lung injury. And as it gets worse, we get what we call acute respiratory distress, or ARDS syndrome. And that's where you're talking about your patients that are usually admitted to your ICU requiring large amounts of oxygen, if not on a ventilator. But something we don't think about is that sepsis related to COVID-19, whether it's a superinfection, superimposed infection, that sepsis itself causes a huge amount of inflammation and can lead to continued lung damage as well. And so those are some things we need to think about as we're talking about COVID and those lung diseases. But more specifically, my focus will be today on trying to recognize those early on and treating early so that we can try to prevent them from progressing. Some patients we aren't going to be able to prevent, but for those that we can, I think it's worth us really focusing in on those patients today. So looking at the screen, as you can see, your normal alveolar in your lungs are like air sacs. They're clear, you oxygenate them well. But what happens with COVID-19 is that those air sacs become filled with fluid. You can see that fluid within these air sacs, and as a part of that, you cannot oxygenate them. The thing that's unique about COVID-19 is most pneumonias that we treat are usually unilateral on one side, with the exception of a few, but this disease tends to be bilateral most of the time. If you're seeing unilateral, you're going to think of another disease, because it's so often bilateral that if you see it unilateral, you need to start thinking, is this really COVID? Patients later on develop the shortness of breath. Typically with patients who have pneumonias, early on they develop shortness of breath as that process of decreased oxygen occurs. But what's really interesting with these patients is those patients a lot of times don't have that shortness of breath. They just feel extremely fatigued. And by the time they're developing that shortness of breath, they're in full-blown ARDS. And you're in that point of having to do ICU admission plus or minus a ventilator. When you're looking at the typical features of the disease that COVID causes, it's what we call, for pulmonologists, we call it an organizing pneumonia. A lot of people call it an atypical pneumonia. Like I said before, it's usually bilateral. It's usually in the periphery of the lungs, and I'll go over some imaging with that, and it's usually posterior as well. Again, 85% of the time, you're going to see it in both lungs. And so if you see it in one lung, you need to start wondering if your diagnosis is correct and start thinking maybe that pneumonia is caused by a superinfection with a bacteria. Let's talk about some imaging that you do of the lungs for your patients. If you're seeing a patient in an outpatient setting, what are some things that you can consider for seeing if that patient has a pneumonia? I want to say chest x-ray is usually sufficient. If you're in a clinic and you have portable chest x-ray where they can actually bring the machine into the room, that's probably better, since you want to avoid sending your patient throughout your facility for risk of contamination. If you have a patient that gets admitted to the hospital, you don't need to do daily chest x-rays. It's not going to change your management. You're going to more likely expose your employees to the risk of being contaminated with chest x-ray, and it really does not, with COVID, and it really doesn't change your management. And if you're early on, your chest x-ray very well may be normal. 30% of them are normal in early disease processes. Your CT scan, we recommend that you avoid your CT scan unless you truly need it. There are some times where you may be thinking about other diseases such as a pulmonary embolus or an empyema, and then you can get your CT scan. But most of the time, half of the time, your CT scans are going to be normal early on in your symptoms, and it doesn't change your risk. And again, like I said, with the chest x-ray, you run the risk of contamination where you can actually expose your employee for a test that may not give you any other information or change your treatment. But if you do find a need to get your CT scan of your imaging, I want us to kind of go over what you're going to see on your CT scan. Ground glass opacifications are usually what you're going to see, especially over early on. And you may not be used to seeing that because usually with bacterial pneumonias, you see consolidation, and usually with viral pneumonias, you see that ground glass. And so what you're going to see is ground glass. You're going to be thinking of viral pneumonia, and that's exactly it. This is a virus, and so it will mimic that. Some have talked about lung ultrasound. A lot of times in the ICU, they don't want to bring that patient, if they're on a ventilator, out of the ICU into radiology to possibly get a CT scan. And so lung ultrasound can also be done. And it's usually you're seeing thickening of your pleura that's consistent with consolidation or a pneumonia. You usually do not see pleural effusions. Pleural effusions are less than 10% of the time. And if you're seeing them, you need to start thinking, or large pleural effusions, you need to start thinking something else like a bacteria superimposed. What you're going to see on your CT scan is really going to depend on where that patient is in the process. Again, early on, days 1 through 5, you're probably going to see that pure just ground glass opacifications. You're not going to see very much. As that time progresses, you're going to see more and more different times. You're going to see ground glass, but you're also going to start seeing some irregular lines and interfaces because it's progressing to that consolidation. And so later on in the course, probably you're 2 weeks out, you're going to start seeing that consolidation. You'll see less ground glass. It'll still be there, and you'll see some reticular opacities, but truly you're going to see more consolidation. And I have some images we'll talk about in a few minutes, or review in a few minutes. Later on down the road, as time goes on, you'll start seeing some fibrotic changes. It's scarring. The lungs become scarred, and you see that fibrosis. And again, like I said, when you do your imaging, you're not going to really see pleural effusions. If you see them, you start thinking about, is there another cause for these pleural effusions, especially those large pleural effusions. If you see cavitation or see lymphadenopathy or nodules, you need to start thinking about a superimposed process such as a bacterial infection. I want to kind of go over some imaging. I don't know if you can see my little pointer. Can you see my pointer, Brian? Okay, great. So this is a typical CT scan, and these are early on what you're going to see on your CT scan. You see all of this little whiteness, that's what we call ground glass. Remember I said that early on you're going to see ground glass opacifications, which you're going to see here. They're going to be peripheral, which means they're not going to be central in this area. They're more going to be out in the periphery of the lungs. And so you're seeing it here, that ground glass throughout. And so as time progresses, that ground glass then starts to do consolidation. And let me see if I can get my pointer, you can see all of this is kind of consolidated white. We see this on CAT scan, and we know that this is a pneumonia. You can kind of see some ground glass here and here. It's still there, so that that process is continuing on. And like I said, in that late, what you'll see is some fibrosis. If anybody has seen the idiopathic pulmonary fibrosis CT scans, this is what you're seeing. These are late fibrotic changes that you're seeing as it progresses. And we'll talk about that. We'll talk about what causes you to progress to that and what are some things that we can do as clinicians to ensure that, or help ensure that that patient doesn't progress along. And a lot of that will be with being on top of things early on and following up with those patients so that before they get into stress, we can talk to them about, hey, you're not looking good. We probably need you to come back in to take a look. This is another one that just kind of talks about, I wanted to show this one because you can see what we talked about. It's usually posterior. So in this area is where the posterior consolidation will be. But you can see consolidation throughout lungs. You see it's peripheral versus more central. you can see there's consolidation as well as ground glass in this. And you can actually, I think, start seeing some fibrotic changes there. So this kind of shows you a progression of what that disease will look like if you're doing. Again, CAT scans aren't very useful early on. It doesn't really change your management. And so we're not recommending that you start with your CAT scans, but these are patients that are being followed over time so that you could see what you expect to see and kind of get an idea of where they are in their course. If you see a lot of consolidation, think either they're having a really hard course or you're catching them further along, even though they've just gotten diagnosed with COVID, they may have had COVID for a minute. When these patients get autopsies, what autopsies have shown is that you get early hyaline membrane with microvascular thrombosis that suggests ARDS. You can also see a lot of those patients had a superimposed bacterial pneumonia. And I say that because I want you to think about those patients that you're treating, to start treating them for a bacterial pneumonia, because what you're seeing on the chest x-ray or CAT scan may very well be the result of the viral pneumonitis, but it also could be a superimposed bacterial infection. That can lead to their sepsis, that septic shock, and that death of that patient. And so always remember to be very cautious with just saying, oh, it's COVID, and not considering to treat it as a bacterial pneumonia. Less common findings, you'll see some amyloid deposits, some alveolar hemorrhaging, and sometimes you'll see on autopsy the vasculitis. Always remember that in COVID, you have increase in thrombosis or clot formation, and so you'll see some pulmonary thrombosis and embolic for some of those patients. Your pneumonia, like we talked about earlier, it's progressive, where you're starting to get those the fluids leaking, or your air sacs filled with fluids, and then you have leaking into the blood vessels, developing into ARDS, and the patient may end up on the ventilator. And as a result of that progression, those patients may end up with scarring, and sometimes that's lasting and sometimes it's reversible. So sometimes that damage is reversible, but it doesn't happen overnight. That patient doesn't get extubated if they've been on the ventilator and all of a sudden they're perfectly fine. It takes months. These patients are symptomatic with shortness of breath, decreased lung volumes for months. And if imaging is followed, you'll continue to see the scarring as a result. So there are three factors that can affect how much of your lung, or affect whether or not you develop lung damage as a result of developing COVID-19. The first is your disease severity. Mild cases are less likely and are more likely to be reversible. Those severe cases are more likely to have a lot of scarring, and usually your severe cases are ones in which you end up on the ventilator and you're ending up with that acute lung injury or ventilator-associated lung injury. And so that can lead to the scarring and that long-term lung damage. The other thing, and we'll talk more about this and we'll focus on, is treatment, what kind of care they get and how quickly. That's important because I know we talk about the remdesivir, and remdesivir has shown that they recover quicker. But I think that we want to focus today on some things we could do as clinicians as an outpatient to help make sure that they get that care pretty quickly, that they know when they need to be, to no longer be at home, and we actually give supplemental oxygen, and we'll talk about some things along with that. Also, their health conditions, if they have underlying chronic obstructive lung disease or heart disease or asthma, they're going to be more at risk to have a lot of lung damage with it. Your older people are more likely to have it because they don't have as much lung elasticity, as well as their immune systems are weakened. A lot of patients are left with permanent lung damage. Scarring that occurs with this inflammatory process, it's not reversible. And so a lot of them, even after they're off the ventilator, they still have shortness of breath and coughing for months and months after they recover. And the CT scans, as we saw, can show some evidence of that scarring, that irreversible, and there's not much that we can do for those patients. As high as 1 in every 5 patients who develop COVID will need ICU treatment. Doesn't mean they're going to end up on a ventilator, but they will end up in the ICU. And so I bring this up because we have to be prepared after this is over with to manage those patients. Our primary care clinics are going to be filled with people who had COVID, who are now dealing with the long-term effects of that. And so we're going to have to be focused on what we can do for those patients to help manage them, because there's only so many pulmonologists that are out there. Again, most patients are going to have mild symptoms, but those who do have serious lung inflammation is the result of what we call a cytokine storm, that inflammation that occurs. And it's why I think you all may have heard about the steroids working with that lungs for patients in COVID. And it's related to the fact that that late course, you're going to see a huge amount of inflammation that's there. And those steroids will help with that inflammation. That inflammation is really what causes your scarring and your damage. And again, there's no way to reverse it, but we can try to help those patients by helping them improve their aerobic fitness, to try to feel better, even though we can't improve their actual lung function. And we can also help patients learn them how to deal with that feeling of breathlessness. Some of the things that we can do, not only with patients who have COVID, but actually after they're recovering, is talk about when they have COVID, there's some, and I'm not going to go into details about this, but we talked about proning. Remember that fluid? And we talked about that fluid being posterior. Well, if you prone your patients, you can actually help open that airway up. You can also do things like doing incentive spirometers, sending those patients home with some incentive spirometers, as well as teaching those patients how to do breathing exercises. I want to stop and take a minute to mention, a lot of you may have received pulse oximeters, and I wanted to talk about that. Well, I'll wait till we get to the end, but I wanted to talk about that as a way that you can help with managing your patients prior to them becoming hypoxic. One of the things I just want to mention is that, we talked about the clots, the pulmonary embolus. Some people develop those pulmonary embolus. And so some of your patients, what ends up happening, especially with those chronic pulmonary embolus, that blood vessel is clotted off forever, if you will. And so you have new vessels that try to grow around that blood vessel. And what you end up with is ending up with pulmonary hypertension. And so a lot of those patients post-COVID will end up, because of that thrombotic or those pulmonary embolus, will end up with pulmonary hypertension. And they'll be seeing you to try to help with management of the consequences of that. So I'm going to shift gears to see what we can do to ensure that your patients don't end up with chronic lung disease. Remember how that slide that I mentioned earlier, it said treatment. 3 of the factors include treatment, what kind of care they get, and how quickly. Let's focus on what kind and how quickly we get to those patients. And so I want to talk about the evaluation of those patients with COVID-19 who may see you in your clinic, or you may have just seen them in the emergency department. It's important that those patients have follow-up, close follow-up, because as things are getting worse, you want them to come into your facility and be seen, and you do more imaging fairly quickly. And so it's important that we do telephone calls on our patients. And I know we're really busy and we have a lot of stuff to do, and so we can't do it every day, but I think there is something to be said about following up those low risk as well as those high risk patients 24 hours after you've seen them, then continuing on through day 5. Hold on one second, and I can't see my slide. But those continuing on day 5, following up just to ask them, hey, how are you feeling? Do you feel short of breath? And a number of things that we can see, and I'll pull that in a few seconds. But those high-risk patients, you want to follow them a little bit more frequently with, see if I can get back to where I was. So those high-risk patients, you want to follow them up a little bit more frequently. You can follow them up on giving a call on day 4, day 7, and day 10, as well as those patients who are discharged from the emergency room. You want to make sure that you follow them up as well, and maybe a day or 2 after they're seen in the emergency room. How frequent you'll follow them up is really depending on how high risk they are, what kind of symptoms they have after you've spoken with them. But always instruct your patients to call if worsening of the symptoms. And that's why I'll talk about, a lot of the areas got pulse oximeters. And so my hope was that when the patients are diagnosed with COVID, that you're sending them home with that pulse oximeter so that they can monitor their oxygen sat. So let's say their oxygen sat was 100 when you saw them, and on day 2, they notice their oxygen sat's now 94. Well, that should be concerning because there's a significant drop in their oxygen saturation. And so that's time where they need to recognize, hey, I need to call my doctor because I may need to come in because I may need further workup. I just want to mention that, your patients who are high risk, and we're all kind of familiar with them, are your patients that are older patients. They're in long-term care facilities, nursing home, chronic lung disease, asthma, heart disease, morbidly obese, chronic kidney disease. We all know these high-risk patients, but I just wanted to remind us that these are the patients that you want to follow a little bit more closely when you're doing it. So when you're following them up, and hopefully it's by telephone, let's talk about what are some things you can do to assess how your patient is doing. First of all, if you have that pulse oximeter, the patient has that pulse oximeter available, ask the patient, what has your pulse oximeter been? Again, if the pulse oximeter is significantly lower than it was when you saw them, then, you may say, hey, you may want to come in for evaluation so we can actually see you. We can do some imaging. But if they say, oh, it's still, it's 96 now, you may want to say, hey, how about you walk for a minute with the pulse oximeter on and then tell me what their stats, because it's really important that you also evaluate them, what they're like when they're actually moving around. And anybody who's having severe dyspnea where they're saying, hey, I can't even take a shower, all of those things, those should alert you that, hey, maybe we need to get this patient in to take a quicker look, especially if this is new and it's progressing on. Now, if they've had dyspnea and you're on day number 14 and they've had the same dyspnea since day 3, then, they're pretty stable and you can say, okay, we'll continue to monitor. But if it's day 3 and now they can barely talk to you while you're calling them, then you know that you probably want to see them come in. And that's why it's so important to actually talk to these patients over the phone. You'd be amazed at how many times patients have been sent to the emergency room because they don't feel short of breath, but you can hear it when they're talking to you. And so part of your assessment should be, are they breathing fast? Are they asking them about their heart rate? Ask them if they're having bluing of their fingers or lips. Asking those appropriate questions so that you get a good assessment of how your patient is doing. And again, I want to mention something that's really interesting, and that was one of the reasons for the pulse oximeters, is that most patients who develop hypoxia don't feel short of breath until they have developed ARDS. And so by the time they're presenting to the emergency room, they had developed such lung disease that they end up either on the ventilator or on other methods to try to keep their oxygenation up. And so it's what they'll tell you is, oh, I just feel extremely tired. I've been feeling fatigued. And they're thinking it's related to, when you get flu, you feel tired, you feel fatigued. So they sit at home thinking it's a part of the course, not recognizing that they're feeling that way because they're not getting enough oxygen in their bodies. And so, again, that's why it's important to get that follow-up. Also assess when you're talking to your patient their mental status. If their family's saying they're confused or they feel confused, or maybe they're having syncope or feeling like they almost passed out, or even just a recent fall, that may make you want that patient to come in, because if they're walking and they do pre-syncope, is it because their oxygen levels are so low, or is their blood pressure so low that now they're dropping? So those are some things that you can evaluate your patient over the phone. And it's important because you want to catch them before they end up in a distress and then they end up in the ICU on a ventilator on pressors. You want to try to manage them early because, again, if they're going to prevent that lung disease, you want to be aggressive in assessing your patients. Just a reminder that patients who have chest pain and chest tightness, any complaints of that, you need to say, okay, while it may be the pneumonia, also remember that they have a lot of thrombosis that goes along. Did this patient develop a pulmonary embolus or acute coronary syndrome? So being very cognizant of that, because that may require another evaluation of this person. And remember, if you bring that patient in to evaluate them and you do a pulse ox on and you say, oh, their pulse oximeter is 95, they're perfectly fine, make sure you walk that patient because that patient's oxygen levels may drop. Hopefully, I'm almost wrapping up. I probably am over time, but I wanted to mention that this is a algorithm I developed, or actually I borrowed it somewhat and kind of changed it from Brigham Women's. A lot of my stuff was borrowed as we were trying to put through protocols. And if you walk through this protocol, it talked about COVID patients. So you're first going to look at your vitals, where their stats. If the respiratory rate's less than 24, their oxygen levels were less than 94% or greater than 94%, you still have to do examining these patients. Doing vitals on these patients don't tell you everything you need. if you examine the patient and the patient looks fine, there's no complaints, they are low risk factor, then you can discharge them home with isolation precautions. But if you do a physical exam and let's say one of their legs is swollen, or you walk them, or their oxygen levels are low, then that may require you to do a further workup with the chest x-ray and basic labs. And even after that, again, we'll talk about the fact that you need to actually walk these patients, because when you walk the patients, you need to be measuring their oxygen, because if their oxygen level drops, your management of that patient changes. You're going to be transferring them to the ER for further evaluation or admitting them to the hospital. So make sure as a part of your evaluation that you do that. And lastly, I wanted to share with you all, and you probably got this in the email, or if not, we can provide it with you. One of the things I did when I sent out the pulse oximeters is I gave the patient handout, and it was in Word so that you could change the information to say, hey, today your oxygen level is 99%, so that the patient knows where they are. But it talks about, number one, how to use the pulse oximeter, but it also talks about how to check the accuracy of the pulse oximeter, because you don't want a patient walking around and they get a pulse oximetry reading that's incorrect and they're running to the emergency department when it was just because they were using it improperly. So that will allow for them. And again, if you're not utilizing that already, I strongly encourage you as a part of your management of your patients that you start using home pulse oximeters so that you can determine which one of those patients. Make sure you're following those patients up. Again, if you want to prevent long-term consequences of the lung disease, you have to make sure that you're following those patients quickly. I think that ends. Hopefully I did my 20 minutes and I'm not over, but if there are any questions, I'm happy to take them. Thank you all.
Thank you, Dr. Johnson. Do we have any questions for Dr. Johnson?
I have a question. First, thank you for your talk. It was really great. My question is there any data to support the use of pulse oximeters at home? And the reason I'm asking is, if I bring, I get the gut feeling that it'll probably be useful, but if I present this to my administrators, they will say, where's the data? Because it will be implied buying, it'll be a purchase, it'll be an economic thing.
It is.
They will want to know, unless it's a research study, that's a different venue, how can I support my request?
So I think that of course, there's no studies right now related to COVID-19 because this is new for all of us. But I do think that having those conversations with them about your thought processes would allow for them, because it makes sense. If you're looking at the data and you look at where these patients are, it makes sense for them to actually do that. And talk about the economics of it. You're preventing those patients from ending up in the ICU and having a lot of long-term consequences of having to take care of those patients. I use pulse oximeter. Again, I'm a pulmonologist, and so I use pulse oximeter for some of my patients just before COVID. Those patients that I felt it was really necessary, my COPD patients, because I didn't want them to increase their oxygen too much because they were feeling short of breath. Hey, look at it. Or patients who may have had anxiety issues where they were concerned about, I feel short of breath, and putting that pulse oximeter on there. And so there are a lot of studies that talk about pulse oximeter in that relationship, but there's not studies to talk about it specific to COVID-19, just because it's so new to us. And it's a huge surprise to us that these patients are not feeling short of breath until they have developed that severe disease. And then at that point, you're off to intubation and ICU pictures. Get them to the point where you can support them with oxygen. Maybe they're a little hypoxia. You can give them 2 liters of oxygen.
And two piggyback questions real quick. So any idea on the cost of them, and also how easy it is for patients to actually use them correctly?
So the cost will depend on where you get them from. They can range from $100 to, I think we got ours, the ones we sent out to the areas were $30 to $50 each. And so it just depends on the brand that you get and the type. One of the reasons why that last slide that I presented to you was related to the patient education. I just presented one part of it. it goes into a lot of detail about the patient, because one of the things that I think clinicians are reluctant to use for, because you don't want your COVID patient running back and forth to the clinic because they're not using it. This instruction talks about how they can correlate what they're seeing on the pulse oximeter with their pulse. If the patient is checking the pulse, which this instruction teaches them how to check their pulse rate, and let's say they put their finger in their pulse oximeter and their pulse rate on the pulse oximeter is 56, but then they measure their own because they now know how to do it and it's 86, then they know it's not correlating, and so they need to adjust it. And that instruction sheet talks about all the different things that they can do, whether it's warm up their fingers, whether it's take off their fingernail polish, well, it's making sure their finger is all the way in there. So that instruction sheet has a lot of details for the patient, so that they can coordinate or correlate those results, because you're right, you don't want, it's like that when we sent patients home with blood pressure monitors, everybody was running to the clinic because their blood pressures were low. And so we want to try it. I wanted to make sure that that patient handout would prevent that.
Thank you.
Mm-hmm.
Any other questions for Dr. Johnson at this time? If not, we can move on to Dr. Mera.
Okay, I can't,
Yep.
I'm not allowed to share my screen yet.
Yeah, I just gave you permission.
Okay. Okay, thank you. So I have to jump out at noon because I have another meeting, and I'm not sure I'll be able to cover everything. So I'm going to start at the end, which is an update on treatment. So the purpose of my presentation today was to kind of summarize what we know and don't know about different aspects of COVID, not touching too much on the lab part, on PCR or serology, because we've done that extensively. And although it's always changing, I just wanted to let's go back to square one and say, and what do we know and what we don't know. But I'll start with treatment just in case we don't have time, and then I'll go back up to the clinical part. So it's important to, and I don't have this slide with me, I showed it to you on the previous presentations, that if antiviral treatments are going to work, they're probably going to be useful at the beginning of the disease and not in the middle or at the end. And this is just based on the experience, basically with influenza, but with many other viral illnesses, that the sooner you start the treatment, that's when it really works. And right now, the only approved antiviral, approved quote unquote, that we are allowed to use it by FDA on an emergency use authorization, is remdesivir. And there have been several studies published on it, and the results vary a little bit, so we still don't really have a good grasp on how good this drug is, but we are using it. And what most positive studies have reported, there is a decreased time to recovery, 11 days versus 15 days compared to placebo. There is some suggestion that there might be a survival benefit, but so far it's not been statistically significant, and we're waiting for more information. Now, the patients who benefit are probably the ones who, like I mentioned, are treated earlier than later. And I know now that Gilead is having some trials with this antiviral combined with immunotherapy, and we'll have to wait for those results. So the indications right now are basically patients who are hypoxic and get admitted to the hospital with or without a vent. It apparently will work better if they're not on invasive ventilation. At least the results show a better improvement, time to improvement in that subgroup. And recently, although this is not a formal indication, but Gilead, I don't know if they leaked out or presented some data suggesting that patients with pneumonia who are not hypoxemic but are admitted to the hospital do benefit from a 5-day course of therapy. And IHS is providing us with remdesivir, and that's what we're using it, and we probably have used it already in about 7 patients. None of them required mechanical ventilation. Famotidine, there's a randomized clinical trial on course. it was an observation in China that patients who were receiving high dose famotidine in the ICU had better outcomes than ones that did not. But there's really no good data that we are supposed to be using this, but there is a randomized trial on course, and hopefully we'll hear some information. And there is some biological plausibility of why this may work, because famotidine can have structural interaction with the virus molecule. Dipyridamole, which is a drug that's used a lot in other countries, not too much in the United States, also has been demonstrated to suppress viral replication in vitro. And there was a proof of concept study on 31 patients that was associated with clinical improvement. And I'm not sure of this one. I don't believe there's a randomized clinical trial on this one yet. Lopinavir, ritonavir, there's one trial that failed. That does not mean that the drug doesn't work for any situation, but it should not be used outside of a clinical trial situation. Ivermectin is pretty interesting. It's an antiparasitic that has demonstrated inhibition in vitro on SARS-CoV-2. It's being actually used off-label in many South American countries and some Asian countries. I have not seen any randomized country studies that are being conducted in the US. It would be interesting because this is a drug that we know what the side effects are or not, and it would be easy to do a study, but I'm not sure why this hasn't happened. Just a reminder that hydroxychloroquine, basically it's even banned from use outside of a clinical research study, and there's no evidence that it works in any way or form. But we still have to wait for the final results from some randomized clinical control studies to be assertive. But we do not recommend this to be used at all. It has a potential for toxicity. Convalescent plasma, we have a little bit more data. So there's good data or decent data on MERS and SARS-CoV-1 that convalescent plasma did help in those situations. We still do not have randomized trials that confirm a clinical benefit. Now, we do have a safety data collected in 20,000 patients with COVID-2, and it showed that less than 1% had a transfusion reaction. Now, having said that, we do inform our patients that it is a possibility that 4 hours after your infusion, you may have a bad reaction. It's very low, but it could happen, and we don't know if this works or not. And we're offering to our patients, it's very easy to get it through the Mayo Clinic. You sign up with them and they will organize for you to get your plasma really quick within 24 hours. And we are offering to our patients. So most of our patients are getting remdesivir and plasma at the same time. And if plasma works, probably it also is something that will work sooner than later when you use it. Now, due to limitations of putting your patients on randomized clinical trials, that's why the FDA has authorized the use of this in situations that you cannot put your patient on a randomized clinical trial. What about other immune modulating therapy so the ones I've included here are the ones that are being tested in randomized clinical trials, and hopefully in the next few months we'll get some better results. All of them, or most of them, have some anecdotal reports on observational studies, and they seem to help, and that's why they were placed on a randomized clinical trial. The only one that we have some results that was mentioned by Dr. Johnson is dexamethasone, but this still, the peer-reviewed publication is not out there. This is just reports, so you have to be very careful. This is a randomized clinical trial with patients from over almost 200 British hospitals, and that study that they report that low-dose dexamethasone reduced death by 1/3 in ventilated patients and by 1/5 in other patients receiving oxygen but not mechanically ventilated. When you look at the numbers, they're kind of tight, but there's plausibility that this may work. Dr. Johnson already mentioned this. But right now, unless you're in a randomized clinical trial, it's not recommended to use it unless the patient has another indication for the use of steroids, like the patient has COPD exacerbation and COVID positive. You can use steroids in those situations. Then I put all the list of the other immune modulators, which is basically interleukin-1 inhibitor, anakinra. I presented the study a few weeks ago. The Italian study was really well done. It wasn't randomized, but it was controlled. And due to the good results they have there, they're doing a randomized study. We have IL-6 immune inhibitors that are being tested, but we don't have any results yet. And also interferon beta-1b, and a bunch of other monoclonal antibodies that act at different stages, either in macrophages or they're kinase inhibitors, protein kinase inhibitors, and we are waiting results. But I just want to show you that this is in the works. We will be getting information in the next few months, hopefully, or maybe a little bit longer. But if these drugs work, they probably are going to be used in where the cytokine storm is happening, which is 10 or 12 days down the road after the infection has occurred. So in the first few days, you have to try to get a good antiviral. And if the patient progresses despite of the antiviral, probably the immune modulators will be helping us decrease this inflammation that the patients are having. Regarding thromboprophylaxis and anticoagulation, there's a pretty strong recommendation that anybody who gets admitted requires low molecular weight heparin to be received. But even patients who are getting this treatment, they still have a lot of thrombotic events. The question is, should we go to full anticoagulation? And that question has not been answered correctly yet. There's some indication from an indirect study of patients who were admitted for COVID-19 in the ICU, and they had other indications to be fully anticoagulated, like atrial fibrillation, or any other indication. And those patients apparently did better than the ones that were not on full anticoagulation. So, but we need randomized clinical trials to do this because we don't know what the bleeding complications could be. But it's based on all the pathology data that has been reported. I think this is probably going to be happening unless the clinical trials do not report any beneficial effect. Quick on ACE inhibitors and ARBs, there's no big changes. Basically, if the patient requires them because they were being treated for a hypertension or kidney protection or whatever, you should keep them. They should not be used to treat COVID-19, and there are clinical trials that are trying to address this question. NSAIDs, if the patient needs it because of whatever condition they were prescribed, there's no indication to take them out. And if you need to use them to manage fever, that's what you're choosing for whatever reason, you're allowed to do it. There's no contraindications in doing that. So we have maybe 5 more minutes. Let me just try to cover a couple of things. So on transmission, we know that it's person to person. Vertical transmission cannot be ruled out. We know it's not on breast milk. Breastfeeding does not have to be contraindicated, but you have to tell the mom that there's a risk of infecting the baby, and you can use PPE and all the protections you want, but at the end of the day, it's the mom's decision. It shouldn't be prohibited by the provider. You should inform the mother. And my take on it is that probably stopping breastfeeding is more deleterious than the risk of COVID-19 infection on the neonate because of all the consequences that could have. But it's a discussion to have with the mother. The virus is shed in stool. Not clear if this has any importance in our pandemic at all. It's also been detected in semen, but there's no studies seeing if it's viable in semen or not. And no cases of sexual transmission have been reported. But I guess if you're close enough to have sex, you're probably close enough to cough it up anyways. So I wouldn't be worried about sexual transmission anyways. Maybe it's a good reason just to tell them to wear condoms for other reasons. So that could be helpful. It's been detected in cats, but what role they play in the reservoir, as a reservoir, we don't know. And definitely do not kill your cat, but do take him to the vet if your cat's sick. The information on viability is not new. This is just old. I mean, old here is 2 months ago, and that has not changed, so I'll skip that. Incubation period, still 5.1 days, 14 days still under quarantine. Now, the important thing is that asymptomatic transmission is more important, more relevant than what we thought initially, and 40 to 45% of those infected will remain completely asymptomatic, and they can spread the virus, and they can start spreading it very shortly after they get the infection. As a matter of fact, pre-symptomatic transmission accounts for 44% of secondary cases. The reproductive number has not changed. It's still on 2 to 2.5 by WHO. And on this slide, the only thing that is changing every week, I think the CDC has a meeting every week on this, and they changed their guidelines. So on close contact is defined as with being 2 meters apart or 6 feet apart for a prolonged period of time. But that's how you define that. Right now, CDC is defining it as 15 minutes. But this has been changing from 10 to 30, I think, and these are expert recommendations, not based on any studies, but 15 minutes is what you should be using now. Risk factors, every study you see more or less the same: cardiovascular disease, diabetes, chronic lung disease. And now, being depending on your blood group type, there could be a difference on having a worse disease or not. And group A seems to be worse than if you're group O. This was good news for me because I'm group O, and probably the only good news I've heard on COVID in the last 3 months. All the other risk factors I have. Black race, Latino ethnicity increases the risk for infection, probably tagged to some social determinants, but not the risk of having a worse disease if you catch it. So that needs to be addressed. We still don't know what are the implications of positive serology, except if you're doing a seroprevalence study, just to know what percentage of your community has been infected. And maybe after week 1 of infection, if your PCR is negative, it could have a role in diagnosis, but this still is unknown, and reinfection potential is unknown. I'll stop there because I have 5 minutes in case someone has a question, but I already sent my slides to Brian, and you can see the rest of it there. And imaging was covered well already by Dr. Johnson, so I'm not adding anything to this.
Great. Do we have any, thank you for your presentation, Dr. Mera. Do we have any questions for Dr. Mera at this time? If you want to type them into the chat, you can do that. Okay, doesn't seem, oh. So let me go ahead and close since we don't have any questions. We are not having an echo next week due to the holiday. We're going to be off that day. And I put the link to the SurveyMonkey into the chat. And I don't think I have anything else. If anybody has anything, speak now. Okay, thank you guys. Have a great weekend.
Thank you.